Well, thanks. It's a real pleasure to speak to you today. And before I get started on my talk, I just want to make a couple editorial comments about Chiari patients. One is, first of all, I'm a headache physician, not a geneticist. So I'm going to present a slightly different angle on EDS than, say, maybe a geneticist might, a much more clinical element. And then the second thing I'd like to say is that headache doctors often follow the Chiari patients, and because we see their prime symptom, one of the prominent symptoms is headache, we often see them and we're often involved in evaluating them for CSF flow abnormalities at the craniocervical junction and so forth. So I would encourage you to involve more headache physicians in some of your meetings so we can start spreading the message. I can tell you that we see no Chiari malformation talks at our national and or regional meetings. But today what I'm going to do is I'm going to talk about connective tissue disorders and EDS. And this is probably a topic that's very near and dear to my heart because I'm hypermobile myself. So that's what kind of fostered my first initial involvement in the area. So what are connective tissue disorders? They're distinct heritable conditions having common reduced biomechanical integrity of connective tissues. So they basically involve mutations in genes that code for collagen modifying enzymes, and possibly other extracellular matrix proteins. So for the patients in the audience, it's those elements outside the collagen fibrils or cells that are involved in the integrity of joints. And it usually leads to ligamentous hyperelasticity or laxity. Now, there are a lot of different varieties of EDS. In fact, you'll count 13 on that slide. But the one that's probably the most common is the HEDS, or the hypermobile EDS. And that's the fifth one down on the list there. And that's one that we see in our clinic, particularly in a headache clinic. I would say that probably 20% of my entire population has EDS, has this hypermobile EDS. So how do you diagnose it? Well, one of the ways is with this Beighton criteria. In fact, if you want to do it on yourself, I don't want anybody to injure themselves today, but you'll see that if you make your hand like a swan and you take your thumb and you try to bring it all the way to your forearm, then that's one criteria. And then if you take your baby finger, your fifth finger, and see if you can get it more than 90 degrees, and you can see that mine goes more than 90 degrees. And then if you take your elbow, and you can see how mine kind of hyperextends there. So if it's more than about 190 degrees of extension, that's another criteria. And you get 1 point for each side. And then the other one is if you take your knees and you actually have to hyperextend them backwards. And a lot of people don't do this correctly, so they don't actually hit this criteria. But if that angle is more than 190 degrees, and then finally with your feet at shoulder width, if you can actually, with your knees straight, if you can palm the floor, then that's another criteria. And there's different criteria based on age for what's a positive Beighton score. So a Beighton score by itself does not prove that you have hypermobile EDS. Now, these were the official criteria that were developed in 2017. And unfortunately, these new criteria, relatively new, I guess it's now almost 7 years old, but they've actually complicated the diagnosis even more. Prior to this, we used to be able to make the diagnosis quite easily with a Beighton score above 5 and hypermobility of the joints. So if you had basically involvement of, or had arthritis in more than 3 or more joints, then you could meet the criteria. But now you can see it's much more complicated. So the first criteria is generalized joint hypermobility. So it depends on whether you're pre-pubertal or, or above 50 or in between. So it's greater than 6 for pre-pubertal children because they tend to be more hypermobile than adults. And then 5 for pubertal men and women up to age 50, and greater than 4 for all those over 50. So a lot of people will lose their hypermobility as they start getting older, particularly when you get above 40. So you may not meet all these Beighton criteria, but you still could have hypermobile EDS. Now, the other thing I would say is that what I already mentioned before is there's a spectrum. So you can be hypermobile, like I'm hypermobile, but I don't meet all the other criteria for EDS. Or you can meet the full-fledged hypermobility syndrome as well with the EDS criteria that we mentioned before. Now, what's interesting to me is all the comorbidities of EDS, because you're not looking at these patients in a vacuum. It's not just about a Chiari malformation and one disorder, but you're dealing with this incredible soup of other illnesses that we call EDS. For example, they often have mast cell disease, and I think you heard a lecture on mast cell yesterday. I wasn't here, so some of these lectures have actually already occurred before I arrived. Panic disorder. So panic disorder is like 13 to 15 times more common in EDS patients than general population. So people will get nervous and they'll feel like their heart races and they develop palpitations with panic disorder. Unexplained GI symptoms. So irritable bowel syndrome is very common in patients with EDS. Fibromyalgia is more common as well. So if you have pain in 5 or more locations, you have neck pain and low back pain and knee pain and head pain and so forth, is very common. Chiari malformations are more common, which is why we're here today. Sleep disorders, dysautonomias. So we're going to talk briefly later about POTS, postural orthostatic tachycardia syndrome, is very common. But the overlying factor with these patients, at least as I see them in a headache clinic, is chronic pain. These people are just live with pain, not just in their head, but all over their bodies. And this can impact how we manage their headaches. And the headaches can impact how we manage other disorders, including Chiari malformations. This was a study that we did. We had a grad student that we had them do headache interviews, both in an EDS clinic and also in a general internal medicine clinic. And what we found was that migraine was more common in patients with EDS. In fact, the prevalence was 3 times greater in patients with EDS than in a general internal medicine patient seen in one of our clinics. And if they had migraine, their frequency was about 1.5 times what it would be in a primary care practice. And if they were disabled, it was 3 times. They had 3 times more disability. So one thing that you'll notice is with these EDS patients, and particularly if they have Arnold-Chiari malformation, is many of them will have coexisting migraine. So you have to differentiate that from other headache disorders related to Chiari malformations. Typically, the Chiari headache is usually one that's more occipital, tends to worsen when you bear down, sneeze, cough, exert yourself, and so forth. And migraine often has different characteristics, although one of the characteristics for migraine is worse with exertion. So you can see that there can be some overlap there. And as a headache doctor, you need to differentiate the headaches that occur with migraine versus those that occurred with Chiari malformations or other comorbidities that we just described. Another one is fibromyalgia, and it's amazing how common fibromyalgia is in these patients with joint hypermobility. It is incredibly common. In fact, these are 4 studies from like 93 through 2007, and the prevalence of fibromyalgia ranged anywhere from 20 to 25% at the low end up to about 80% on the high end. So fibromyalgia is extremely common in patients with joint hypermobility. Now, the classic triad that we see in our patients is hypermobile EDS, POTS disease, so postural orthostatic tachycardia syndrome, and then also we also see mast cell disease, MCAS. Now, one of the tip-offs for mast cell disease for me is when I see a headache patient and I see that they've got about 25 different med intolerances, then I'm thinking, what's going on? That's just so outside the ordinary that maybe we're dealing with a mast cell disease. And then POTS syndrome, which basically is where when you go from a lying to a standing position, that your pulse goes up by more than 30 beats per minute. So you don't need to do like something called a tilt table test to diagnose this. You can just do measurements of blood pressure both lying, and then 3 minutes later, you can check their pulse and blood pressure again. So if it goes up by 30 beats per minute, or if it goes up above 120 upon standing, then that could meet the diagnosis for POTS syndrome. And that's very, very common. So when you're looking at So if hypermobility is associated with Chiari malformation and you're using autonomic symptomatology to try to diagnose whether there's brainstem compression, it can be very confusing in that situation because we know that POTS is comorbid with joint hypermobility syndrome. Now, what is mast cell? You probably heard a lecture, so hopefully I'm not reiterating what was said yesterday, but it's non-clonal mast cell activation, and the symptoms are secondary to release of cytokines and other mast cell mediators. And many have like anaphylaxis. So if someone's had a past bout of anaphylaxis, particularly if it was from an unknown exposure, it's not like a bee sting where you have anaphylaxis. So you get swelling of your throat, you get rash and hives and swelling all over your body. Sometimes you need an epinephrine shot. These patients often have unexplained anaphylaxis in the past. And often they have many med intolerances and allergies, which we already mentioned. Now, this is just a picture for the physicians of all the many mediators that are released from mast cells. I think we all know of histamine, but there's tryptase and there's a variety of prostaglandins and leukotrienes and so forth. So there's a lot of different things that get released in this disorder that relate to many of the symptoms that these people have. So what do they have? So in this chart, there's typical for just mast cell activation and then typical for mast cell activation. And you can see the ones that are most positive for mast cell activation are they can have unexplained syncopal attacks. You can see that with Chiari malformations as well. They can have tachycardia, and they can have some GI symptoms, flushing and urticaria, but not as common as some of the there's other secondary causes for mast cell activation, but that don't meet criteria for MCAS. This is the diagnostic criteria for MCAS, at least one of them. Typical clinical signs of severe recurrent systemic mast cell disease involving at least 2 organ systems. So you could have like involvement of the skin with various skin rashes and skin disorders, GI symptoms that often resemble irritable bowel syndrome, etc. Involvement of mast cells is documented by biochemical studies. Often they'll get a tryptase, but the tryptase level in the blood is often normal. We often do urine studies looking for urinary prostaglandin and histamine measurements as well. And they have to have a response to mast cell stabilizing medications, drugs directed against mast cell mediators, or drugs blocking mediator release. These are some of the meds we use, and in fact, in headache patients, we will often give patients this cocktail of meds involving antihistamines, H2 blockers, anti-leukotriene medications, and sometimes mast cell stabilizers, and some monoclonal antibodies are used as well. So we often work very closely with allergists that have an expertise in this area. Now, the other thing, I'm just going to touch on this because I know that Dr. Gray is going to be discussing this in a minute, but because of the elasticity, not just in the ligaments of their joints, but in the dura itself, oftentimes patients with joint hypermobility can have CSF leaks as well. In fact, this is a study from the Mayo Clinic that reviewed 58 consecutive records of patients with spontaneous CSF leaks, and 9 had evidence of a connective tissue disorder. 6 were joint hypermobility, and then 4 were arachnodactyly, if I can pronounce it, and 2 were skin laxity. And then Cedars-Sinai found a much higher prevalence of 66% in their patients with leaks. I will tell you that because the Beighton criteria can be a bit challenging to actually perform, that I would guess that this is probably underdiagnosed in that population. Hence, I would say that probably joint hypermobility is probably underdiagnosed in those with Chiari malformations as well. You have to know how to do the criteria, and actually, like a lot of people, like even with this criteria here, we try to oppose the thumb with the forearm, you'll get down to almost positive, and then you're afraid to push it all the way down. And I'll usually tell the patients, I'll say, all right, can you push this all the way to the forearm? And they'll say, absolutely, because I don't want to hurt them. And I think a lot of times you miss the criteria because the doctors don't, or the providers don't know how to do the test. Oftentimes, EDS patients can get these meningeal diverticuli, which are shown by the arrows on the slide. And oftentimes these can leak. You can have venodural fistulas that occur with these as well, which predisposes obviously to orthostatic headaches. So the classic kind of headache they get are headaches that are worse when you stand up and better when you lie down. Now, the exact opposite, this is also something that's not well recognized in patients with hypermobile EDS, is the relationship with high pressure. And you say, well, why would that occur? And we'll discuss that in a minute. But these are the official criteria for high pressure. They have to have papilledema, so swelling of the optic nerve on exam. They have to have a normal neurologic exam, except for something called a sixth nerve palsy. Normal neuroimaging of the head. normal CSF composition, and an elevated opening pressure over 250. Although I will tell you that many headache doctors, actually it was mostly because of what Linda has told me before, is that lower levels of CSF pressures, maybe even like in the 18 to 25 range, may be associated with headaches, but they may not have the papilledema. So I think that 25 centimeter cutoff is good for identifying those with papilledema, but it may not be the best cut point for headaches. Now, this is another study. Actually, was published in 2024. It was a case series of patients that had EDS, but they also had jugular venous obstructions, and they basically did arteriograms and venograms, cerebral arteriograms and venograms, and found that a lot of them had obstructions of the internal jugular vein. And you can look at the numbers on the slide, but overall, 35% of them had a venous outflow obstruction. So why hypermobile EDS would actually predispose to that, I don't know, but it's an interesting observation at least in this case series. Now we'll talk about Chiari malformations. This is probably, I tried to find, some real well-done studies looking at EDS in patients with Chiari malformations, and this was probably the best one. But you can see in this study in the chart that this is a study by Millerot that was published back in 2007. And he basically found that about 12.6% of his population actually had connective tissue disorders, which is much higher than the population as a whole. But what you see is that look at what happens to the clinical presentation in Chiari when you have a connective tissue disorder. It just basically amplifies every symptom. And I'll just highlight a few. Look at dysphagia, 69% versus 26% in those that did not have hypermobile or did not have a connective tissue disorder. Sleep apnea was more common. Blocking out spells were more common, 14% versus 1%. Other things would be Raynaud's phenomenon. So that's where your fingertips turn blue. Orthostatic hypotension, so your blood pressure falls when you stand up and your pulse goes up. POTS disorder was more common. The other thing I thought was interesting too was that cervical disc disease was more common, which kind of made me think that maybe the intervertebral ligaments being more lax leads to more play of the vertebrae and might lead to more disc herniations. And because I've often wondered, why do a lot of my headache patients, why in their 20s and 30s are they getting, disc herniations? You wouldn't expect that to actually happen, but maybe in those hypermobile patients that there's a predisposition to that. So it's just an interesting observation. But the bottom line is that when you take people that are hypermobile and they have Chiari too, the soup of diseases they have is greatly expanded. Now let's talk about craniocervical instability. I think you had a lecture on this yesterday. So the way I look at my talk is it might be kind of a unifying talk to many of the ones that you've already had. And there are a number of spine abnormalities. You can get craniocervical instability, atlantoaxial instability, Chiari malformations. You can get segmental instability or kyphosis. You can get spontaneous CSF leaks, which we already talked about. Tarlov cyst syndrome and tethered cord. So there's a variety of different spine abnormalities that can occur in EDS. There are a variety of different radiologic signs, which you as neurosurgeons in the audience know far better than I, but there's obviously the clivo-axial angle, which I believe was discussed already at this meeting, Harris measurements, Grab-Oaks measurements, etc. And those are the descriptions of those or demonstrations of those on the radiographic slides. So what are some of the symptoms of craniocervical instability? They include things like suboccipital headache, dysautonomia and POTS, pain, numbness, weakness, and sensory loss of the extremities, visual symptoms, blurred vision, scotoma, scintillations, apneic episodes, disequilibrium, so you're off balance, you can have vertigo, dysphagia, dysarthria, and problems with sleep architecture. I will tell you that if I didn't know anything about Chiari malformations, I can see all of these symptoms in just people with hypermobile EDS. Now, whether they're because of this or whether they're completely separate, because we know that, say, POTS syndrome has a number of different causes. maybe one of the causes, maybe that one of the causes could be a Chiari malformation, I suppose. But there's a lot of overlap. So when you're trying to decide whether someone has craniocervical instability and they've got POTS and they've got all these other syndromes, you really have to be careful, because you could actually attribute a symptom to craniocervical instability when in fact it's from POTS syndrome or some other dysautonomia or mast cell or some other disorder that's mimicking craniocervical instability. So I know that Dr. Henderson's in the audience. This was his criteria for surgery: diagnosis of a connective tissue disorder by geneticist, severe suboccipital headache or neck pain, symptoms of cervical medullary syndrome, demonstrable neurologic deficits, and then a variety of measurement abnormalities, the radiologic measurements, and then failure of conservative management. Often they'll put them in a trial of a cervical immobilization first as a test to see whether that actually improves the craniocervical instability. And then in cases that don't respond to more conservative measures, then there are surgical procedures such as occipital to C2 fusion and also C1, C2 fusion. So in conclusion, and I'd be happy to talk to you about this maybe in the Q&A if someone has questions, but POTS and MCAS are common disorders that occur in patients with EDS. And I will say that CCI, my plea at the beginning to maybe involve headache doctors in some of this is the headache doctors know nothing about this. In fact, I gave a lecture to one of our national meetings about craniocervical instability, and they were totally clueless. So if we're going to be the ones that end up referring many of these patients to you, there needs to be an educational effort to educate them on what angles they need to look for on their flexion extension MRIs, and to educate them on what patients might be candidates for surgery when appropriate. And then it's also possible, as I said before, that one of the syndromes or one of the associated diseases with hypermobile EDS may actually mimic some of the symptoms of either craniocervical instability, maybe even Chiari malformation. There could be overlap with them. So the challenge for us as clinicians is to try to tease out what's causing those symptoms and do they need surgery or conservative medical management, which is what I do in a headache clinic. Thank you very much.